And I'll invite Nick to come back to the stage. Where have you gone, Nick? I can't see you. You're hiding. You're there. Come up and join us on the stage. I should put my glasses on, shouldn't I? I'd also like to invite Andrew Montague, who's Chief Executive of the Central Coast Local Hospital District, Dale Fisher, who's CEO of the Silverchain Group, and Matt Jones, who's CEO of Murray PHN, to join us. So you folk have all done some evaluation. So we've just heard that evaluation is part of this. You've done some evaluation. I'm keen to hear a little bit more about what you think, your reflections on integrated care in Australia, what the enablers and barriers are. So I thought I'd start with Andrew to give us a perspective around acute care and your experience in that space.
Thanks, Alison. So I
think there's a microphone there, yep. You good?
Just try another one. There should be another. Let's just pick up another one.
So I think for us from a Central Coast perspective, we were a demonstrator site for New South Wales when integrated care was rolled out. And I think the thing that highlighted it for me is that the staff that weren't involved with the program saw it as an added extra onto the side. And as we transition out of the demonstrator phase, that is one of the biggest challenges we've got, is actually teaching our clinicians and more importantly, very good. Is that better? There we go. So just to recap, shifting from being a demonstrator, where really it's been seen as a project, to being seen as something where integrated care is the principle that we should all be thinking of when we're providing care on a day-to-day basis. As a demonstrator, just a couple of things I was going to highlight, and I won't touch on two of them in terms of outcome-based commissioning, which was a great presentation yesterday done by Macquarie University, and also our integrated care manager, James Wilson, presented yesterday on the family referral service that we have on the Central Coast. But one of the big ones for us has been our central care multi-agency response team. And what that team has been is actually sitting together people from not only the health service, but FACS, so Family and Community Services, which is now Community and Justice in New South Wales, and also education, where all of these people that were managing kids that were vulnerable, a lot of the time would end in out-of-home care, actually sitting together in the same office space and actually having that opportunity to talk face-to-face on a daily basis. They would hold huddles in the morning, huddles in the afternoon. They would actually be able to identify where things weren't going right, whereas in the past, it may have been via letters or emails and people may not have actually even known who one another was. So we're just in the process of evaluating that particular program, which certainly anecdotally has shown a lot of promise. In our transition, I think one of the key things is that we're continuing on the journey with New South Wales Health. And New South Wales Health certainly is investing in integrated care and value-based care. We're one of the pilot sites for the integrated care chronic care program, where we're integrating with our electronic medical record, and I think a lot of the work that's been done in Victoria with Health Links in terms of putting risk assessments for chronic disease patients into the electronic medical record, so that the staff in the hospital, when people are coming in for an acute episode, they're actually identified and able to be better linked into our chronic disease management programs and other programs that are occurring across the health service. And the other exciting piece that we're doing, and once again, this is a good example, you don't need to reinvent the wheel. We were quite a long way back with our aged care teams in terms of them going out in the flying squad type response to aged care facilities. So we're introducing a flying squad which will go out to start with 4 residential aged care facilities. And the amount of buy-in that's been able to be gained in terms of having those conversations with the aged care facilities, seeing what their actual problems are, and actually understanding what they believe is required, that's actually going to make a difference, not only for them as service providers, but for the facility clients that they have. The other big things, and I think the being a demonstrator site has allowed us to do this, is we've now formed really strong relationships with other non-government agencies on the Central Coast. And as a result of that, we've actually, coming out of the demonstrator phase, have actually agreed on what our priority areas across agencies will be. So there was a great response, not only from these agencies, but we held community forums as well. And the number one thing that came up, and we're focusing very much on youth, is mental health. So there's been both a top-down and a ground-up approach with this. So in terms of a grounds-up approach, we've had a number of high school principals have banded together and have been working with health, where we're actually looking at that promotion and early intervention stage with kids between 12 and 18 years in schools. And it's got to the stage where a lot of other learning groups across the Central Coast are now actually approaching us, and it's really growing organically. But what we're doing at the same time, we've got a massive gap at the moment for 0 to 12-year-olds. So what we've been able to do, because of the relationships formed with other agencies, is actually get together and start doing the gap analysis and actually looking at how can we do this different going forward? How can we pool resources and funding to actually provide a service that will meet the needs of our community? Last thing, so I don't take all the time up, I guess probably my takeaways from a barriers and an enabler and opportunities perspective, in terms of the barriers, probably the biggest barrier we've had is the culture of our senior clinical staff, and in particular our medical staff. We've got, I won't name the particular specialty because we're live streaming, but one of the groups of senior clinicians just could not see the point in them going out and running clinics in a multidisciplinary approach in a GP practice for I might as well say it, diabetes. And once again, it came to this whole thing that they wanted total control. And we've used all of the processes of bringing them data and showing them this is where the high risk area is. And it's taken us over 6 months to now get to the point where we've actually started with them sitting in the clinics and working together. But the amount of effort and energy that's needed to go into something where it looked quite obvious that this was going to be a positive has been really, really quite difficult. And that real hospital-centric approach, I think, from a health perspective, we're still very much focused, and I think a lot of this is political and building hospitals. And if we're still focusing on infrastructure as being the core thing because the community can see it, it's going to make it even harder for us to continue to change the way where we start thinking about care in the right place, which a lot of the time can be in the community or at home, and a place which actually suits our clients. In terms of enablers, for me, the key thing is building good relationships with your partners and with the community. And it's being open and transparent and building that degree of trust where you can call one another out, because without that, you actually can't go forward. And also utilising the IT that you've got. I think Health Pathways is a great enabler. I think a lot of different places across the country at different stages in the use of Health Pathways, but it's something that I would really advocate. And for me, I'm really excited for the Central Coast, obviously having someone the calibre of Nick being our inaugural research director for our research institute. We really will have an opportunity to have education, research and service provision based in our health and wellbeing precinct, but really the Central Coast will be, in effect, an incubator for being able to try different ways of providing care and services. So we see that as a huge opportunity, which is really exciting, and we look forward to working with people that are interested in this room. Thank you.
Thanks so much, Andrew, and a bit of an applause for being brave and calling out those that get in the road. Andrew mentioned the value of relationships, and particularly the broader community and with NGOs, and Dale is CEO of Silverchain, a community group. So Dale, over to you.
Thanks very much. Still on? No? Yep, okay. Hello everybody. Yes, Silverchain is a national provider of health care in the home and aged care in the home. And our mission is to care for Australians in their home and build the virtual health system. And we partner with mainly public health organisations, and of course one of our signature projects is Western Links in the west of Melbourne, and also in New South Wales and the west of Sydney in palliative care. So we had the advantage many years ago in Perth, where the organisation was founded, where the community services were built up first, particularly in palliative care. So the death in home rate in Perth is over 50%. What differentiates Silverchain is that while we provide community care, we actually provide specialist health care, palliative care physicians, nurse practitioners who are palliative care specialists. And so we've learned a lot in the West. We're doing a lot of practice in South Australia, and we're looking to do more and more. I'm very pleased to hear a CEO is partnering and has the philosophy right. I think a lot of our programs also are coming from a place where it's still skewed to the acute care, as in hospital prevention, rather than the public health benefit. And we talk about governance, both clinical governance, which Silverchain does have a strong clinical governance framework, and practice where it differentiates us from other healthcare providers. But we also are very keen on evaluating what we do. And we're also guided at the end of the day by what we call community governance. What does the community expect of us, and how do we steer and develop our services at that point of care? So this is about integration. We definitely, even today in the posters awards, I would suggest that next year that the awards go to partners who can demonstrate they've integrated together rather than the individual silo who might have had the initiation. So it's about, you know, having a lens of integration right from any organisation, and I think the evaluation is very interesting too, and I was fascinated by the presentations. I've just come back from Israel on, you know, the startup nation, where they accept failure and learning, and culturally Australia, all of the overlay on, you know, you have to demonstrate the value of it. It's very hard to, you know, evaluate that, but we need to learn from what we're doing in our practice, and there has to be more scope from governments, federal and states should require it, to actually learn from the terrific stuff that's going on, not just with Silverchain, but also with health services, with academic institutions. And I think Australia can lead the way. Instead of being the startup nation, we can be the integrated care nation.
Thanks so much, Dale, and a great emphasis on relationships there, and an idea for the awards next year. Matt, relationships are everything in a primary health network. Tell me about it.
Hello everybody, my name is Matt Jones. I'm the CEO of Murray Primary Health Network here in Victoria. And I think one of the things that make it very difficult for us to enable effective integrated care is the structural barriers that not only we work in spite of, but in many ways exacerbate the challenges of how to provide effective integrated care. Fundamentally, I think there's three significant structural barriers, each independent but each interrelated, that we need to look to ensure are accommodating in our efforts to improve our efforts for integrated care. From a patient point of view, our health needs have changed significantly over the course of the last 50 years. We know in terms of morbidity, mortality, we proportionally don't have the deaths and illnesses associated with trauma and early infections, but we have seen the explosion of chronic disease and psychological distress. They're complex needs. We need team-based care, and our system of the primary health care doesn't enable the provision of healthcare with a multidisciplinary approach, particularly in the context of the second barrier around the way in which we provide healthcare. As I mentioned, I am the CEO of a rural primary health network, and fundamentally our health system works well where we've got economic capacity and large populations in close proximity. But once we start talking about smaller populations stretched across geographical areas, our reliance on a system that is funded through, underwritten by government, but a private structure for MBS, PBS, means our communities aren't able to access multidisciplinary care, aren't able to access the complex care needs that can be only provided where there is capacity that enables access, that enables quality, that enables the equity of services. Gets to the third structural barrier around the way we finance our health system. We value volume over our value. We fund outputs, not outcomes. We fund the initiation of team care and mental health care plans, but not the completion. We don't fund roles to enable a more multidisciplinary care approach. So we need to have different approaches rather than trying to jam this square peg into a round hole, which I think moves to the enablers, and probably a long-winded way to answer your question, Alison, around the relationships. We have to start, and I particularly enjoyed your presentation, Nick, around the identification of having a population-orientated and a people-centred approach to integrated care. We need to look at population needs. We need to build scale through regional approaches that are delivered at a community level. Particularly in regional areas where we do have small populations, we can't amalgamate health services, we can't centralise populations, but we can build partnerships. Building partnerships between, at a community level, the acute health services and the primary care services in a vertically integrated way so that the management, administration and the clinical capability isn't expected to be replicated across the road from each other under a Commonwealth and state approach, but literally have a partnership at a community level around the health capability. Coupled with that, horizontal integration between primary care providers across multiple communities for a platform for investment in multidisciplinary care, mental health, care coordination, supported by blended funded models that enable not only the utilisation of MBS and PBS, but also complex care packages so that the needs of those with aged care, chronic disease, disability, mental health can be incorporated in roles that support that multidisciplinary approach. And then thirdly, with the incorporation through that partnership model of block funding through the state system so that roles like nurse practitioners, practice nurses, not only become referral points, but actually embedded in the primary care team at a community level. We're really pleased to be undertaking a trial with the federal government and the Victorian Department of Health and Human Services at a population level of 3 local government areas, looking at exactly that approach called integrated health networks, where we are building a partnership of scale across a region, delivered at a community with a blended funded model in 13 general practices, 7 health services, and looking at a new way to build those partnerships so that not only we have team-based care, but importantly also have team-based working environments that provide the mentorship, the supervision, the peer support, and importantly the destination for training pathways. So I think it's a combination, it's a blended solution looking at a regional context, a population-based context for patient-centred care.
Thanks very much, Matt, and for picking up on the point that Nick had made about the shift from a provider-centred approach to a person-centred approach. I'd be keen to hear from our other three members of the panel, Yvonne, Andrew and Dale, as to what your views are around that shift from provider-centric models of care to patient-centric models of care. What can we do? What are you doing and what do you think should be done?
The narrative of Silverchain is choice. I believe we need to move from choice about a person, centric in controlled care into it's actually a rights issue, a human rights issue for the patient to be, or client, to be in control of their care. And it's currently still in the control of the provider, whether that's an individual or a health service.
Yep, that's great. Andrew or Yvonne?
I think, I'm an evaluator, so I'm going to talk about evaluation. I'm sorry. We really need to understand what it is that people need and want and how that fits in with what is already happening. And so you really need to bring not only the families, the patients, and the community on board. You do need to talk to providers as well, because in the end, it is the providers who are involved in care also, right? So it's a partnership. And of course, they work within a system. So to me, it's a three-way thing. It's patients and families, it's providers, and it's the system that needs to work together. And I think only when we achieve that will we be providing care that is of high quality and is the care that's actually needed.
Thanks, Yvonne.
I'll probably answer it from two perspectives. Operationally, across New South Wales, we're rolling out patient-reported outcome measures. And just touching on something was mentioned yesterday, I think the importance of it actually being in real time, for me, that's the real critical thing, and making sure that patients, when they come in, the clinician that's seeing them has an opportunity to actually see those things that really impact on the patient's life, rather than, I think historically we've just got caught up in medical jargon and lingo and what it means to the clinician as opposed to what it really means on a day-to-day basis. And I think the other big thing that we're looking at from a research perspective as we go forward and develop our institute is that we actually want the community to help put up what the research questions are, rather than us telling them what this is the research and the things we need to do. So very much our focus will be on integrated care and population health and seeing what actually matters to the community that's going to mean they've got a much better level of well-being.
Thanks, Andrew. Nick, in your presentation, you talked about an area near the Lakes District, a small rural area that was grappling with very similar problems to those that Matt described. And what I'm really interested to understand is, how did the governance of that model work such that you were able to achieve the successes that you talked about?
Well, it's unusual, but I think it's an English system, so very different to Australia. So you have the propensity to have pooled health and social care budgets that are provided on a capitated basis according to the need of those local populations, and that's provided to the authority across Cumbria. So you have this resource, and there's activity-based payments and so on, but you've got to live within that resource. So automatically you have a group that is place-based in these different areas. So you're trying to create areas of which there is a direct connection to local people, and the governance for the money primarily sits with the joint commissioning authorities, which is the health and social care. However, what they have created are 20 community care organisations. So on the local governance, not a statutory governance, on the local governance, the community and the community partners are coming in as members of that group. So the priorities that are created for each of those 20 different communities are different, and they're born from conversations with local people, and you're trying to bring in all of those community assets to be part of that solution. So we go to Millom, one of the interesting ones was that where do people mostly go? To the laundrette. So we create a health literacy, health initiative in and around the laundrette because that's where people meet. And you've seen it in other places too, where you're using libraries or using other public resources, or you're doing it within industry. So if you can provide a way in which all of your community assets are coming together to create a suite of kind of health promotional, healthcare interventions, you're creating a culture across that community where people have ownership of the problem. So they not only have democratic accountability to them locally, they're also invited to be part of the solution in a meaningful way. And I think that's one of the reasons why they've been so successful over such a short time. Also, they have great people, and this is the miracle clause in the equation. And I think the people there have somehow infected, I don't know how they've done it, but they've kind of injected people with an integrated care gene as they've gone around the different communities so that people can understand and feel that this is the way forward for Cumbria. So very quickly, as a result of demonstrating the impact in one place, oh, I want one of those and I want one of those, and suddenly it's creating a movement because you've been able to demonstrate the benefit somewhere else. So why don't we have one? It's not about a hospital, it's about I want to have control and representation on the future of my community. Not necessarily on health, it's the future of my community. It's very interesting, but it's just what they've done locally. And I think the other thing is, this thing about local context and what you're doing sounds really interesting as well. But I think you have to self-determine your own future. I think if you wait and look upwards for something to happen, all you get is a crick neck. You know, so you've got to just, all of the best integrated care projects all the way around the world did it despite the system, because they knew it was the right thing to do.
Thanks, Nick. Yvonne wants to say something, so if you'd pass the microphone up, thank you.
So I'm sitting next to a CEO of an LHD and a PHN. What I'm about to say may not resonate with you. But in one of the projects that I've been involved with, governance structures certainly got in the way. I think our health system is actually not prepared for change, not ready for change, not agile. So even when there was funding and there were additional positions brought in, situating that funding and those positions, both within the LHD and within the PHN, there were barriers. So barriers to actually releasing program funding to get the program work done. Even in terms of the position descriptions for the coordinators and the managers. The managers also, you know, within the system, within the LHD and the PHNs, were all focused on KPIs. And why is the manager and the coordinator having coffee all the time with everybody? She's having coffee with everybody because she needs to make relationships and make connections in order to implement this program, which is an integrated care program which includes the community and NGOs. And so there's this misalignment between what we want to achieve and what the machine of healthcare and the governance of healthcare is used to doing.
Matt or Andrew, any reflections on whether your staff go out to coffee enough to build relationships?
Do you want to go? Why don't you go first?
Well, some of my staff are in this room, so I suggest they might regard that I lead by example in coffee consumption, actually. I do think it touches upon what you mentioned, Dale, in regards to that we have to be prepared to take risks, and that means permission to fail, that it isn't about KPIs, it isn't about a checklist that we need to ensure that every box has been ticked. The realities of generating place-based solutions that are predicated on relationships means that this is an art more than a science, and it's around tapping into that creativity, tapping into the ownership. I spoke of the trial that we're doing across 3 local government areas, the ability for those communities to have more ownership over healthcare, given they know the precariousness of the current state of play, has been something that I've been significantly surprised at. I expected that perhaps was going to be the hardest sell, trying to convince change. But I think a big part of it is around providing a platform for engagement, providing a capacity for ownership, and then tapping into that, nourishing that, allowing that to foster and develop without a predetermined checklist of this is where we need to be and how we're going to get there. I think it's about the creativity and the support.
Andrew?
I think it's a very fair comment. We've formed a formal alliance with Hunter New England Central Coast Primary Health Network, and we've been quite deliberate, so it's only 2 years in the making now, but we deliberately set up a charter outlining what we were both trying to achieve. We've deliberately actually pooled funds to bring on board a manager for the alliance so that it's not one partner playing off the other. And we've also put funds into the project I spoke about before that took us quite a while, was co-funded. But I think it's very fair to say, and I think this is some of the mindset of some people who've got stuck in that rut of, to achieve, I've got to meet a KPI. And I think that's part of it. It's changing that whole message, that going back to actually let's focus on the patient and our community. If we do a good job, we'll actually meet the KPIs. So I think the key thing though is it's just consistent messaging, talking to people. There's always going to be barriers, and we just need to be persistent and overcome them.
Thanks. Dale, you're with an NGO that no doubt has KPIs embedded in your integrated care contracts. What's your view on KPIs? Are they an enabler or a barrier? Where do you sit with that?
Look, they're necessary with any, accountability structure, whatever an NGO or a government or... but I think we do get skewed too much into that in the initial. Mm-hmm. So in any co-design project, you're trying to leverage the energy, it requires leadership. And even if I could challenge Yvonne on, we've got to treat everyone equally in terms of the provider or the patient. When you're trying to achieve equality, you have to treat groups unequally in order to get equality. So if you are behind like women's rights, or you have to, youth, so any population group who are behind, or diversity, you actually have to have your organise around that so that they can advance. So this even Steven is rubbish, I could say. But back to the KPIs, look, I think that again, going back to the patient or client, them determining from their point of view, we could make a giant leap. And I think a lot of the time, if we're live streaming to government, there's a lot of bureaucrats who keep their jobs in designing just unrealistic KPIs who does not have an impact on the service or the outcome for the client.
Thanks so much. Look, I'm going to try and sum up what I think you five have made some really quite revolutionary statements here today, and I'm going to try and sum these up. So Nick wants really a change in our gene pool so that we can be genetically inclined towards relationships and community partnerships. So I don't know if we're going to... Yes, so I don't know if we're going to achieve that anytime soon. You've all alluded to the need to actually have a greater risk appetite and to actually be a little bit brave. And you've all been brave. You've challenged bureaucrats, you've challenged colleagues. You've also talked about community ownership, and I think that's a really key word which I haven't heard much in the discussion around integrated care, not only here, but actually generally. So let's flag that as something which we might want to pursue a little bit further. I think you all gave really quite a good sense around culture and what we need to do with cultural change to drive organisational and behavioural change. But I really liked a couple of points that a couple of you highlighted. Dale, you talked about community and clinical governance and the role in this, and I think we underplay that very much, particularly when we start moving outside of formal structures like hospitals. We underplay the need for community and clinical governance. So really important that you've raised that. Matt, you talked about some of the geographic issues and the rural and regional complexities in particular when we move into small areas, as did Nick. And I think we need to put that at the top of mind as well. Yvonne, you've talked also about evaluation and needing to start and continue through the process of a design and development and implementation of a project, not just at an end point. And I think that's a really important learning to take away from here. And Andrew, you've been really brave. You've really tried to bring together a project in real life. And, it's going to be really interesting to see what happens at Central Coast. I'm in partnership with the PHN, with the university and others. So thank you very much, all five of you, for a great session. And thank you to all of you for participating. I'm sorry we haven't had time for questions, but the good thing is that it is afternoon tea time and these five are captive here. So try and catch them and ask them questions if you want to. Thank you very much.